Welcome, everyone. Today, we're taking a deep dive into the surprisingly complex and honestly fascinating world of temporomandibular joint noises. If you've ever felt a pop, a click, or a weird grinding sensation right in front of your ear when you chew or speak, you are absolutely in the right place. We're going to decode the mystery of that clicking jaw and look at exactly what's happening mechanically inside your head. But more importantly, we are going to cover the absolute most critical step you must take before you even think about going to a physical therapist or a chiropractor to get it worked on. Because getting it wrong can actually make things much worse. The mechanics of your jaw are incredible, so let's figure out how to protect your bite, your comfort, and your long-term health.
Okay, let's dive into this. Is your popping jaw actually a problem? You might be sitting there right now thinking, look, my jaw has clicked for years, it's just a weird quirk. And hey, you wouldn't be alone. Temporomandibular disorders, or TMD, are incredibly common. Up to 40% of the general population deals with them at some point, and this specific symptom disproportionately affects women, especially between the ages of 18 and 45. But here's the thing, just because it's super common doesn't mean it should be ignored. That little clicking sound? It's basically your body's check engine light flashing, letting you know there is a very specific mechanical event happening inside your joint.
To understand that click, we've got to decode a bit of medical jargon. What you're highly likely experiencing is called disc displacement with reduction, or DDWR for short. So let's break that down. Inside your jaw joint, there's this tiny, shock-absorbing cushion called the articular disc. It sits right between your jawbone, the condyle, and your skull. Disc displacement simply means that this little cushion has slipped out of its proper place, usually sliding forward. Now, the with reduction part is the absolute key here. It means that when you open your mouth, your jawbone snaps back onto that disc, popping it right back into its normal position. That violent little snapping action, that is literally the sound you are hearing.
Let's visualize the exact mechanics of this. That pop typically happens the exact moment your jaw opens past 10 millimeters. Picture this. As your jaw drops down and glides forward, the bone reaches the edge of that slipped disc. Right at that 10 millimeter mark, the bone forcefully slips over the back rim of the disc and pops perfectly into place. It is a sudden, physical repositioning. And you know, patients often describe this sound as incredibly loud, almost like a loud crack right inside their head. That's because of local sound conduction. The sound travels through your jaw and skull bones directly into your ear. So even if the person sitting right next to you at dinner can't hear a thing, to you it sounds like a firecracker going off.
But here is where our narrative takes a really sharp turn. I want you to ask yourself this crucial question. What happens when the clicking suddenly stops? Most people would totally celebrate. They think, oh great, my jaw finally healed itself. The noise is totally gone. But I really have to warn you here. A suddenly silent jaw is not necessarily a cured jaw. In fact, an abruptly quiet jaw after months or even years of clicking can actually signal that your joint has crossed the line from a manageable mechanical hiccup into a much more severe, fully locked condition.
Now, what's really interesting about this comparison is the stark contrast between a jaw that clicks and one that is completely locked. When you have reduction, which is your standard clicking jaw, your jaw still functions relatively normally, opening a perfectly healthy 45 to 50 millimeters. But when reduction fails, the clicking stops, because the disc has slipped so far forward and become so deformed that your jawbone can no longer pop back onto it. At this point, the disc is literally acting as a physical roadblock. There's no sound anymore, sure, but your jaw is locked. You can suddenly only open 30 millimeters or less. Your jaw visibly deflects to one side when you try to open it, and it's usually accompanied by pretty significant pain.
And this brings us to a massive, absolutely critical warning. This whole progression is exactly why you should never undergo standalone physical therapy, manual stretching, or chiropractic adjustments on your jaw before getting a proper dental diagnosis. If you blindly stretch or forcefully adjust a clicking jaw too early or in the wrong direction, you can actually make the disc displacement way worse. You risk triggering intense joint inflammation called capsulitis, permanently deforming the disc, and causing sticky adhesions to form inside the joint. Pushing or pulling on an undiagnosed joint can drive a clicking jaw straight into a permanently locked jaw. You must have this checked first by a qualified dentist so you know exactly what that disc is doing before anyone touches your jaw. So how do we find out exactly what the disc is doing? The answer is magnetic resonance imaging, an MRI. It is the absolute gold standard and that crucial one thing you usually need before starting any manual treatment. Listen, standard X-rays only show bone. They are practically blind to the soft articular disc and the surrounding ligaments. An MRI allows a specialist to look right inside the joint to see the exact position, shape, and health of that disc in both open and closed mouth positions. Getting this imaging is a vital, non-negotiable step to understand the internal mechanics before anyone starts pulling, adjusting, or prescribing aggressive exercises for your jaw. Alongside an MRI, you need a highly focused clinical exam performed by a qualified dentist who truly understands TMJ mechanics, bite, and airway. They are going to go through specific calculated steps. First, they'll closely observe your jaw opening, listening for both that loud primary click and a much subtler reciprocal click when you close. Second, they'll precisely measure your maximum opening between your top and bottom incisors. And third, they'll exert gentle, carefully guided pressure to test for joint resistance and pain. This isn't just a quick visual check, it's practically a structural engineering assessment of your jaw.
And here's another critical reason why proper imaging and a dental evaluation absolutely must come first. Sometimes, what seems like a simple everyday jaw issue is actually something entirely different, like mandibular condylar hyperplasia. This is a condition where one side of the jawbone continues to persistently grow, causing facial asymmetry and totally shifting your bite. Imagine trying to fix a slowly growing bone with standard jaw stretches or manual adjustments. It wouldn't work, and it would waste incredibly valuable time. A qualified TMJ dentist uses imaging to rule out these rare but serious conditions, so you don't end up going down the wrong and potentially harmful treatment path.
The overarching theme here is that TMJ is a coordinated structural dental problem first. It is deeply tied to the complex relationship between your teeth, your bite, your airway, and your jaw joints. Because this is a mechanical joint issue, conservative, evidence-based treatments managed by a dentist are always your best starting point once you have a proper diagnosis. Once that structural baseline is established, factoring in your bite alignment and airway health, your dentist can then safely prescribe and bring in targeted physical therapy or other providers as part of a highly coordinated, unified treatment plan.
Let's look at what that coordinated treatment plan actually looks like in practice. For acute pain and inflammation, short-term NSAIDs are highly effective. But the real heavy lifter in this lineup is the oral splint, which stabilizes your bite and decompresses the joint. Once that splint is securely in place and doing its job, that is when supervised physical therapy is introduced. Notice the word supervised there. This means specific, passive jaw motion exercises prescribed safely because we already know the exact position of the disc from your dental workup and your MRI.
And this brilliantly illustrates the secret weapon in TMJ care, the anterior repositioning splint. Now, to be clear, these are not those soft, squishy, boil and bite mouth guards you buy at the pharmacy. These are hard, custom-made, horseshoe-shaped acrylic devices meticulously designed by your dentist to fit over your teeth. Their purpose is incredibly specific. They gently hold your lower jaw slightly forward. By doing this, they reestablish the correct relationship between the bone and the disc. They take all that nasty pressure off the joint, allowing the deformed isc to decompress, recover its shape, and ideally, stay captured right where it belongs.
When we combine these therapies properly, the results are fantastic. Clinical trials have shown that a coordinated plan using carefully supervised exercises alongside custom occlusal splints results in a 30% reduction in the severity of joint noise within just a few months. It totally proves that physical therapy is incredibly effective, but only when it is part of a deliberate, diagnosed strategy. It's a team effort. The splint provides the vital mechanical support, and the exercises train your muscles to adapt to this newly stabilized position.
Now, if basic splints and exercises aren't quite enough to fully resolve the pain, there are excellent secondary options that are still entirely non-surgical. We're talking about procedures like arthrocentesis, which is essentially a gentle, targeted wash of the joint to remove inflammatory cells and unstick those stubborn adhesions. There are hyaluronic acid injections to help lubricate the joint, and even platelet-rich plasma, or PRP, which uses your own body's healing factors to promote tissue repair. There's also laser biostimulation to reduce muscle pain. These are highly targeted, minimally invasive tools your TMJ specialist can utilize if needed. And how well do these slightly more advanced yet non-surgical treatments work? 91. That is the staggering percentage of success reported for procedures like arthrocentesis, specifically in cases of disc displacement with reduction. 91%. That number is a massive reassurance. It proves that in well-managed TMJ care, well over 90% of cases can and absolutely should be treated without open surgery. It is yet another huge reason to start with the right TMJ dentist for conservative care and splints, rather than assuming you need a major operation or rushing straight into standalone physical therapy.
So the crucial point is this: we absolutely must respect the mechanical complexity of the jaw. If you have a clicking, popping jaw, step 1 is knowing what you shouldn't do. Don't blindly stretch it or let anyone forcefully adjust it without knowing the true underlying cause. Step 2 is getting a comprehensive clinical exam from a qualified TMJ dentist, factoring in your bite and your airway, backed up by an MRI. And step 3 is treating the root cause, starting with conservative, coordinated care like splints and properly supervised therapy. Protect your joint by treating it smartly from day 1.
We've covered a ton of ground today, from slipping discs and MRI imaging to customized acrylic splints and the absolute vital importance of looking before you leap into treatment. Your jaw is a total marvel of engineering, but like any intricate machine, it requires precise diagnostics when something goes out of alignment. That clicking isn't just an annoying sound. It's a story of your anatomy, warning you to get a clear picture before anyone starts pulling on it. So I'll leave you with this question. Are you ready to stop ignoring the noise, get the right diagnosis, and truly listen to what your jaw is telling you? Thanks for joining me on this deep dive. Keep learning, keep asking great questions, and take care of yourselves.